This conference will now be recorded.
For the one new gent who is here, welcome everybody. First of all, sorry, should have said that first. I'll come back to the intro, but for the one new gent, Eric C., we do record the meetings. Maybe you've listened to us on the recordings. We do that so, number one, people can go back and catch anything that they missed. And number two, some people can't make it. Some people don't want to be here in person. They prefer to listen to the recording. So that's why we do it. Feel free to change your name. Feel free not to show your face. It's fine by us. We just want to be here to help you. That's our agenda. Welcome, everybody. It is the 7th of July. We were away last week, so it looks like this could be a record-breaking attendance today because we're already up to 53 on a normal meeting. So that's a lot of peeps. I want to thank our sponsors who are Johnson & Johnson, Foundation Medicine, Bayer, Myriad, Blue Earth, Telix, and Bayer. I think that's everybody. If people could mute if they're not talking, that would help us so we don't get background and we don't get feedback. And just one quick announcement from me, which is my apologies to everybody. I screwed up and put the NCCN professional guidelines and patient guidelines as one as the same link to the patient guidelines. So next week's reminder, I will correct that. If anybody wants it before then, send me an email. I don't think I'm going to have time to be able to go hunt it out and put it in the chat window. Maybe somebody else can. But those are important guidelines, as I said in the reminder. They tend to be the foundation for all standard of care, and there are several people who put them out for the advanced cancer for sure. I would say that those NCCN guidelines are the gilt-edged ones. They're the gold standard, and so it's good for you to have. They're a little difficult to read. You sort of have to get used to them in the professional version. In the patient version, they should be easier, but they're not always accurate. We got 42 changes in last time. Thank you, Captain Fisk. Richard just put the link for the professional guidelines that I screwed up in the chat window. So just click on that and you'll be able to read them later. So if your doc says it's not available or we can't do that and it says something different in those guidelines, you just show them the guidelines. All right. So we're starting with Eric. And Eric, have you watched us before on
Right. So I've watched recordings of your meetings.
Good.
So I have a sense of the flow of what occurs.
Okay.
And if I recall correctly, I think your newbies get introduced initially.
That's exactly right. And I'm going to go through as quickly as I can because we have a lot of people who need time tonight. So I'm going to ask you a bunch of questions, and we do it this way so we sort of keep it more structured. So how did you find us on YouTube originally?
I was given a heads up that I probably should be looking you up, finding you on the internet by a friend who knew of my diagnosis.
Okay.
And he's a pharmacist, a retired pharmacist who is a close friend of mine. So close friend referral.
Okay. And are you signed up to our group? Are you getting reminders yet from us?
Yes, I am.
Good.
Yeah.
Okay. How old are you?
73.
Okay. And where do you live?
Captain Cook, Hawaii.
Ooh, okay. We haven't had we have a bit of experience with Hawaii. In fact, quite a lot. But we haven't had anybody. Well, we have. We've got a regular from Maui who's not on tonight. But we haven't had any new people from Maui, so we do understand the challenges.
I live on the Big Island.
Yeah, we understand the challenges. What year were you first diagnosed?
2024.
Okay, and at the time of your diagnosis, what was your Gleason score and your PSA level?
PSA level was 11. My Gleason score was 4+5
Okay,
in 13 out of 14 samples.
were positive. And
Yeah.
were you diagnosed on the island?
I was diagnosed. Yes, I was diagnosed here on the islands. That's correct.
Okay, and are you a Kaiser patient?
No.
Oh, good. Okay. I was fearing that question. I was fearing that question. Um,
No, yeah.
okay. So, how did you tell us how you came to be diagnosed and who diagnosed you?
Right. So, in June of 2024, my GP, I asked my GP to start including, because he'd never asked to include my PSA
Mm-hmm.
in the blood work, and it came back at 8. And he said, we have to look at that. And come November, it was at 11. And he said, "Oh, you need to go see a urologist." And it so happened there was a brand new guy in town who had flourishing, very active practice in Washington, who had just moved in, had a long history and knew a lot of people who I
Mm-hmm.
got along very well with. And I uh, they did a digital exam, then they did the biopsy. It got sent to Honolulu, and it came back. And I met with him shortly thereafter, and he said, "Okay, yeah, you're going to have to get serious about this." So he was quite frank with me. I mean, here in Hawaii, with anybody who's got a serious medical issue, looks for professional help elsewhere, frankly. And and I was absolutely in favor of that. And I started looking around for recommendations.
Mm-hmm.
He referred me to either UCLA or UCSF on the West
Mm-hmm.
Coast. Obviously, West
Mm-hmm.
Coast is easiest for me. I
Mm-hmm.
happen to have a cousin who lives just north of UCSF, my favorite cousin. And so he referred me to UCSF, where I then began the following year after having, before I actually went to San Francisco, I ended up with PSMA. Um, and sure enough, I've got oligometastasis to the lymph nodes outside of my prostate. And at my age, and given my circumstance, and having read through a lot of material and books, came to the conclusion that radiation therapy was really my method. Prostatectomy was
Okay.
probably not a
So
good idea for me.
who did he refer you to at UCSF?
Max Roach.
Mac.
I think you know him.
Mack,
Yeah,
M-A-C-K,
Mack.
not
Mack.
Mack. So I do know him very well, and he knows me very well. In
Yeah.
fact, we have to get him onto the advisory board because he finally agreed to do that when I saw him in February. But it's my bad because I haven't followed up with him.
That'd be
He
good.
got me a continuing durable remission 17 years ago, so I have no complaints. What? Let me guess. 2 sessions of SBRT and 25 sessions of to the pelvic girdle. Am I
I
close?
ended up with, yeah, close. I ended up with the 5 sessions up front.
Okay, just 5 sessions
But
up front. So
no,
where?
plus the 25 after.
Oh, he did 5 up front.
Yeah.
Hmm. I wonder why. That's interesting. Did he say why he was doing 5 and not 2?
Well, his overall theory is that he wants to do a heavy duty boost up front
Mm-hmm.
before I get into uh, the normal radiation treatment. And in my particular case, I have a particularly aggressive tumor. I'd had a my I had a decipher score rating of 1.0,
Okay.
and I think he wanted to really go after it.
So
And
what else showed up
so
on your? What else? Did you ever get your biopsy reread by anybody, or was it just read by the
I
people?
no, I had it reread by UCSF.
Okay. Um,
Um,
and and did it have any unusual criteria like cribriform or intraductal or anything like that?
well, yeah. So cribriform, let's see, I think cribriform 5 is what we ended up with.
Okay.
Um, and I have some more technical information, but essentially every time I would go and get an exam, um and my wife and I would wait with bated breath, waiting for the results. It always seemed to be far less than what we would hope it be. But you know, when you're in the initial stages, it's always a shock.
Well, you mean far less in terms of what they told you, or far
No,
less?
no, no, no. Um, I try very hard to be an optimist, and these are not optimistic reports.
No. So,
However, I'm still here, so that's
right.
good.
And you're going to be here for a long time. So, what you're
Bingo.
as you're, so you had metastasis to the lymph nodes in how many
Yep.
places according to the PSMA?
According to the PSMA, I had 3 lymph nodes that were involved, that had metastasis.
Okay.
Um,
And what about outside the lymph nodes? Did you have any? Did
no,
anything show up anywhere else?
nothing showed up.
Okay, so you're in good shape. Just want to tell you, 4+5, only metastasis to the lymph nodes, um, is great. I mean, it was enough to convince Mac that he could get away with SBRT and IMRT for you. What hormone therapy are you on?
So, I started off with Lupron. I had some Casodex up front,
Right.
and then they put me on abiraterone
Okay.
through. Let's see, I started the Lupron on May Day, a year ago May Day,
Right.
and then went up and I had my radiation treatment in San Francisco through the month of August and September.
Mm-hmm.
after which they started the abiraterone as a secondary. The
Mm-hmm.
abiraterone played havoc with my liver enzymes, and so I had to stop that.
Mm-hmm.
And I am now taking enzalutamide.
Okay. Um, and do you have, is Mac overseeing this, or do you have
So,
a
right. So
medical oncologist?
I have a local medical oncologist. We just got a resident medical oncologist local who's a really cool guy and sharp. And we're very, very fortunate to have him on board. And I meet with him on a 3 monthly basis. But I insisted on continuing with my initial medical oncologist at UCSF, um, Dr. Washington. No, not Dr. Washington. He did the.
Yeah,
Uh,
he's a Euro. Who's
uh,
your GU med onc at UCSF?
yeah. Oh, okay. I knew you'd ask me about that. I've got it here. Can I get back to you on that?
Yeah, yeah,
Dr.
just let
Younger.
Younger. I don't.
Yeah.
I've seen his name. Don't know him at all. But I have
Yeah.
seen his. But I've not had. He wouldn't know me, and I don't know him.
Yeah. He's a
But
young guy,
yeah,
PhD, really
yeah.
sharp, and I'm
How are you managing on the enzalutamide?
Eh, you know, I daily hot flashes, multiple hot flashes, fatigue, brain fog.
Okay.
That's about it.
All right. So the normal, the normal. So we'll talk about that a little bit. And have they scanned you since you finished all of this treatment, and what are they seeing?
No, they have not.
They have not. So we don't really know. Um,
Correct.
did you do any genomic testing?
Yes, I did.
Okay. What
And
was the result?
there, I did a germline, and there was no indication that it was a something that I inherited or that I would
Okay.
pass on to my family. That was really good news.
Okay, but they didn't do a somatic test for you.
No,
Okay. Well,
only the germline.
I would probably ask for it. I mean, you qualify for one with that with those um, distant what those pelvic mets. I'm assuming those lymph nodes were all in the pelvis. Is that right, or were they elsewhere?
No, it was in the pelvic arena. Yes.
Right. I mean, you could, and I happen to think it's not a bad idea to have it because it gives you sort of a baseline. You can see if you've lost something or gained something along the way, and it might point something out. So you could just as easily have a BRCA mutation that's somatic as you could have one that's germline, and then it would change your treatment pattern. They don't seem to do it, but I think if you ask for it, you could get it. The problem is now it's going to be hard because of the hormone therapy. I should have asked you, but I just sort of assumed that you're undetectable. Is that right?
That's correct.
Good. Okay. How quickly did you get undetectable?
It took about, and I assume you're talking about from the initial Lupron shot.
Yeah.
Uh, uh, it took about 3 months.
Okay, that's great. I mean, that's what you want. If you would have told me 6 months or 9 months, I would have had it would have concerned me. But that's exactly that's right on the money. So it means you're responding great. And what we know now is that you have a very good outlook because there's recent research that ties into a lot of that. And we know that if you hit that low level very quickly, you have exceptionally good outlook for your disease for a
Uh,
continuing durable remission. Well,
Appreciate
what
the comment.
I'd like to talk to you, may have some questions I'm going to ask you in a second, and we'd like to talk to you maybe a little bit about how to manage the hot flashes, and the fatigue and everything else. So if people want to start putting their hands up as to addressing those, but what questions do you have for us, Eric?
At this point, Rick, I am just glad to be able to find other gentlemen that are in a similar circumstance. I'm pretty open about my diagnosis with my colleagues and friends and my golf buddies and whomever it happens to come up with. I mean, I'm not hiding in any way, but there's really nobody that can really relate. So I'm just glad to find a group of guys that,
Okay. Well, I got news for you. You got 54 other guys in this room right now who can all relate, each and every one of them. And we will start off with my two moderators who both have their hand up, and Len's first in line and then Ben. So Len, please go ahead.
Thanks, Rick. Eric, I may have missed it, but why were you switched from abiraterone to enzalutamide?
my
Liver,
liver,
Oh,
my
okay.
liver.
liver can handle
Okay,
it.
thank you. Also, maybe this is more for Rick than for you, Eric, but Mack Roach gave a long presentation at PCRI. I don't know if you caught it. He was very blunt and frank and sassy. Anybody else see it? He was talking about urologists saying that you should have surgery because if the surgery fails, you can have salvage radiation. And he said that's horseshit. And he showed data of 2,000 patients who had radiation and subsequent surgery after that. So, but it was interesting presentation. That's it.
Thank you. Was that at the most recent session?
Yes.
Okay. No, I didn't watch it, but Mac's always entertaining. For those of you who don't know, he also has another claim to fame. He's Hank Aaron's son, nephew. So and he gave the eulogy last year or a year and a half ago when Aaron's died. So Ben.
So, Eric, you had started to talk about technical information in your pathology. We're all adults here. You can tell us what it is.
Okay. Pardon me. I'm just going to take a moment to locate it because I have literally a pile of paper here in front of me. If you'll, while you were talking, I should have been digging it out. PET CT, illness. Of course, it's not right. Is that it? Yeah. No, that's the original.
Thank you.
Oh, I know. It's on a yellow paper.
So whilst Eric is looking for that, and hopefully he can multitask even whilst he's on Lupron and enzalutamide.
Yeah.
And I know it's very difficult, so I shouldn't ask you to do this because it's hard enough when you're not on the HD, but when you're on the HD, it's even harder. But we'd love to recommend a couple of solutions for your hot flashes if they're driving you nuts. One of them is the Ember Watch, which if you look at the screen, somebody's bound to be who's got an Ember on? Anybody got an Ember on? Oh, yes, okay, Richard Craymond. Oh, no Jeff Marchie today. I wonder where he is. He usually has one. These are gizmos. Have you heard of them before, Eric, or not?
No, I have not. Ember or amber?
Ember, EMBR.
EMBR.
And I'm trying. I'll see if I can get it. If not, by the way, do you know where the chat window is? It's the little two
Yeah.
little squares, and there's a lot of stuff
Yeah.
going on in there. And
Yeah.
let me get you a reference for that. But the Ember watch is something that you wear on your wrist. It works for some people. It doesn't work for others. There are both categories in this group right now. But the it sort of intercepts a neural point and stops the hot flashes. It senses when you're getting a hot flash. It stops it. It's effect. Len, what percentage of you guys is it effective for? You wrote that. You wrote the blog. You wrote the reminder post, Mr. Sierra.
Oh boy, I did, and I wish I could remember. I'll just say 67%. I think that's a ballpark answer.
Yeah. So you know,
Wow.
it works for 2/3. It doesn't work for everybody. I am about to put the link for you. You can get them from Amazon. You can get them from the company. We've been working with them for years and years, even when they're in trial. And
Got it.
there is thank you. Somebody Alfredo put the Amazon link in there for you, so you can go.
Got it.
Can go from there, or you can just Google Ember and you'll see it. And there's a nighttime setting as well, which can be really, really helpful because I must have woken up 5 or 6 times a night from the damn hot sweats. There's also a very good option with acupuncture can work, but you have to keep doing it. But there are acupuncture points that we know, and we can send to you if you want them. So you keep looking, and I'm going to go to Dr. John and then John G, and then I think we may have to wrap up. Dr. John.
Here's our best way to deal with the fatigue. And I'm sorry to say that it's not taking naps. Just keep moving. Really, we really want you to exercise at least moderately, at least 150 minutes a day, a week, maybe 200. Keep exercising. It'll help with all your side effects, and it may even inhibit chances of recurrence.
Yeah,
I'm kind of an exercise person, so
that will do you well. Don't let it fall by the wayside as the tiredness accumulates on you.
Yeah, I'm an ocean swimmer, so I live close to the ocean, and 2 times a week I swim 1.5 miles.
Good for you.
That's excellent. That'll be great. Yeah.
Good for you. Keep doing it. Keep doing it. But also don't forget you need to get some weight resistance in there too. Really, really important. I mean, I was an aerobic endurance athlete, and I did more weights when I was on hormone therapy than I've ever done before, and I could actually lift more. So you've got to mix it in. John G, what's on your mind?
I just had a question. How have they talked about how long they want to keep you on the hormone therapy for?
Yeah, so this is kind of a moving target, frankly. They talked initially about 24 months, and we've talked as I'm into the treatment already. It's been expressed that it may in fact end up having to be longer than that. But I'm going to try to hold them to 24 months if I can.
Yeah.
That's quite a common recommendation, Eric, 24 months.
24.
Yeah.
So just to let you know, because it'll be good fuel for you. Matt told me originally 28, because at the time, and I'm going back 17 years, the studies were something like 6 versus 28 at that time. And then somebody came out with 18, and then somebody came out with 36. And I said, Mac, do I need to do that? He said, who knows? He said, each one's different. We don't know. We'll see how it goes. He kept me on 28. I will tell you that my PSA rose to 0.98 in the 11 months after I came off, which is pretty normal. There's a reason for it. I can explain it at some point or the other, not now. And every time I call Mac and he said, oh, don't worry, it's going to go down. Oh, don't worry, it's going to go down. I'd say, easy for you to say, Dr. Mac. He's
Yeah.
going to. Sure enough, it peaked at 0.98 and then it went down. And I'm very fortunate because I wasn't quite as serious as you. I was only stage 3 with metastasis outside the gland, and it did go down and it stayed down. So, that's another thing. Don't be surprised if it rises and rises when you come off before it settles down. But Mac won't keep you on longer than you need to be. I can't talk about younger. The guy who you're seeing, does he have any background? The med-onc you're seeing on the Big Island, does he have any background in genitourinary or not?
Yeah, his name is Brian Erickson, and he had a full-blown practice in Oregon that where he was kind of a go-to guy in a pretty affluent community that he left because his wife loved Hawaii, and so their loss is our gain.
Your gain. But here's the thing, if he was a general medical oncologist, and he's a general medical oncologist, he doesn't have the knowledge. He just doesn't, because he can't keep up, because he's got too many things to keep up with. And that's why it's really important to keep Younger and Mac totally in the loop, because if something doesn't go right, then you're going to rely on them. As Mark Valens will tell you, you'll hear in a couple of minutes when Mark speaks. And you become, you can have a terrific local person like Mark does, but they don't have the depth of knowledge. God forbid you need it, which right now you don't, because you're in that pattern. All right. I'm going to move on because we've got a lot of people who want time today. And if that's okay with you, Eric, and keep coming back. We're here every week, as you know, except if it's the 5th week in the month. And
if I may, Rick, I was just going to throw in one thing. You had asked me if I found my additional.
Oh yes, go ahead.
Second opinion, and this came from UCSF. It's a reading it, and it's about cancer biomarkers. They tested for tumor mutation burden and microsatellite instability.
Yep.
In my case, both are indicating that I'll probably end up having this migrate into
something more complicated. So what was your MSI? What was the actual level of your MSI?
Yeah, MSI was 1 of 85, 1.18%.
Okay, but did they not give you an actual MSI high reading?
Well, they said it was less than 20%. It makes it.
Okay.
Yeah, it makes it go to cast. It'll probably evolve into a castrate-resistant.
Okay. What about your TMB? I mean, normally they give it to you as a number, so it'll be.
Yeah. Well, so my TMB is 4.1 mutations per MB.
Okay.
is a
I'm
low
thinking
T.
that maybe that percentage is what they usually express as the number, Ben. Maybe 18. Yeah, MSI could be 18 then. I'm not sure because I'm used to it as
So,
being an absolute number.
so well, it says here 1 of 85 tested microsatellites were found to be unstable. This is interpreted as microsatellites stable.
Microsatellite stable, so which is fine. But they didn't do a testing to see what somatic mutations you had.
No,
Okay. And what about that biopsy report that Ben's interested in with all the technical information?
this cancel biomarkers is all I have. I don't really have in front of me the second
Okay.
reading. What I do know is that they probably backed off slightly. Initially, mine was a T3A or T4A. I think it was T4A, and they
Yeah,
backed it
T4A.
to
Yeah. So, yeah, I mean, it might be interested, but sounds like your MSI stable, your TMB's within line, so all that is solid. Eric W has a question for you. He wants to know: have you gained any weight during your treatment?
No, in fact, I quit drinking and I've lost 10 to 15 pounds.
Good for you.
Yeah.
Good for you.
Ben, were you trying to get a
I feel
comment in there?
comfortable with that.
No, okay.
All right. Do I have permission to move on from my fellow moderators? I'm
I
seeing
vote to move
Thanks for
on.
the time, guys.
pleasure. Keep coming back. We'll help you. Like I say, we got a lot of experience of people on the islands who have come to the mainland for their treatment. UCSF, UCSD, and other places, UCLA and other places too. So you're in very good company.
Thanks,
Um,
guys.
let me just do one thing we don't normally do. Is there anybody who knows that they've got to leave early? Just indicate with your hand. If not, we'll get through everybody, but it might take a little longer. But anybody who asks for time who has to leave early. Okay, I don't see anybody right now. So I hope nobody says, "Oh, I gotta go," when they ask for time and I didn't get to them. Here's your
Excuse me, Rick. Excuse me,
yes.
Rick. Bob, let's see, Bob Alvoid raised his hand.
Well, I was just going to run off to grab a bite to eat,
Oh.
for about a half an hour or so.
Yeah, but you didn't ask for time, did you, Bob? This week you
I
said
did not.
no.
Yeah.
So I'm only looking for people. Anybody can leave whatever they want. I'm only concerned about the people who wanted time and then they have to leave, and then I feel very guilty, and I can't sleep at night. Well, that's not true, but I don't want that to happen. So I'm going to try and make a habit when I do it to make sure I get. If I know somebody's got to leave, we get to them. So we're going to start with Mr. Valens, who has excellent experience working with people at the centers of excellence as well as local medical oncologists. Is that true, Mr. Valens?
Yes, but that's not what I'm. That's not what I want to talk about tonight.
That's okay. You don't have to.
I just want to see if you guys can help me understand. I'm trying to figure out what's going on with my body because I can't quite figure it out. Um, I started Pluvicto back in January, I think, and PSMA scan showed excellent response. That it really knocked all my Mets way back and shrank them, and no new ones were starting in. But my body was telling me something else. I was feeling worse and worse and worse. And I'm trying to get another PSMA scan, but boy, they're still booked out another 10 days. I've been waiting for a month. But my question is that, so I went ahead, I was able to get in for some MRI scans, and they're showing that the cancer is spread a lot into my spine and onto my skull and down in my pelvis. But the last PSMA scan showed everything was gone. So my question is, I know that the regular cancer can morph into neuroendocrine. So my question is, can I have both at once? Is it possible that the Pluvicto did knock back all the regular cancer I had, and so we thought we were clear, but it didn't do anything for the neuroendocrine, so that kept working away, and we weren't paying enough attention soon enough, and it's spread a lot. Does that make sense?
It makes sense, but as you recall, we did get a biopsy and we did send it off for Epstein or Zhu, I forget. I think it was Epstein to look at.
Zhu.
Zhu.
That was over 6 months ago.
Oh, that was 6 months ago. Okay, so the answer is it does make sense. It's what Rahul, I suspect, is thinking is happening because he's talking about carbo plus cabazitaxel. And yes, it could well be. And my feeling is that if we had an easy place to biopsy, we might look again. The problem is that just because you don't have it in one spot doesn't mean you don't have it in another spot. You could have it. So so we could biopsy and we may not see anything, and it doesn't really matter. At the same time, there are other tests, and Rahul knows them, and he's going to be maybe asking you to run tests for somatostatin, and what are the other ones, Len, that we always talk about? The other tests that might give an indicator for small cell disease.
Chromograminase, synaptophysin.
Thanks, Jack.
So, like what we did before, we compared the PSMA to an FDG. And so, Rick, you brought that up. And so I suggest, and because neuroendocrine might show up on one, but not the other. And so if they're showing something different, there's neuroendocrine there. And so I suggested we try that again to Rahul. And he said, "What? No, we already did the FDG, and it showed you didn't have any positive response." But that was over 6 months ago too.
I think you need to point that out to him and say, "Look, that was 6 months ago."
Well,
and I would like to see it again. Ben, what are your thoughts on this?
Mark, I'm sorry about this news. That's the first thing that comes to mind. Yes, I mean, what you suspect certainly sounds plausible to me. I'm surprised that Agarwal, of all people, is not more energetic about following up.
He says we have to wait to get the PSMA before he wants to make any decisions. But like I said, I'm finally going to get it in 9 days. But it's we've lost 6 weeks waiting for it.
Oh,
yeah.
Time is of the essence with neuroendocrine.
It is, and your fatigue ties into a possible small cell. I'd rather call it small cell rather than neuroendocrine because it's neuroendocrine like, it's small cell neuroendocrine like, as opposed to pure neuroendocrine, which is we see very rarely, which is where it starts out as neuroendocrine, but it basically looks like neuroendocrine and acts like neuroendocrine. I would think that get that PSMA. I mean, even if it means if you're up to it traveling, go somewhere where you can get it quicker, and then I definitely would be doing an FDG PET to compare it, because
Well, and Dr. Sander, who's my local med onc, she's not a GU med onc, but she's gone ahead and ordered another biopsy. You don't quite know where to get the biopsy from, but I know this getting it from bone is not the best place. The last one we did was the adrenal gland, but she's trying to come up with some soft tissue.
yeah,
Go ahead and do another biopsy.
yeah. I mean, that would be great if we could do that. But again, just prostate cancer is not homogeneous in how it expresses the neuroendocrine. So just because you don't have it in one place doesn't mean you might have it in another place.
Okay.
So there are some diseases where they are consistent. What we do know is that usually the metastases that we see, the mutations that we see, they are pretty much the same throughout wherever you've metastasized. But that doesn't mean to say you couldn't have neuroendocrine in one spot and something else in another spot. Anyone else want to comment on this who hasn't spoken up yet? Dennis.
Thanks. I didn't hear anything about liquid biopsy. Is that an option for looking for the small cell neuroendocrine like?
No, it's a good option for looking at mutations, but it's not a great option as far as I know for identifying because you see the the pattern. It's a what's the word I'm looking for, Ben? Morphologous.
Morphology.
Yeah, it's the morphology that we're looking at now. What may happen is that, and it might be worth doing another repeat liquid biopsy, is certain mutations might come up which might give us a better indication that might be more common in neuroendocrine small cell like, but it doesn't confirm it. Would you agree with that, Ben, or not?
There are a lot of tests coming online is just kind of a premature way to put it. They have new approaches that are much better than what they have done in the past to diagnose neuroendocrine treatment emergent neuroendocrine prostate cancer. They have DLL3 imaging. They have Amisha Beltran has done something with liquid biopsies, and it just seems a shame that at a research institution like UCSF that they can't think of something more innovative to track your disease.
Yeah. I mean, the problem is that these are great tests, but they're not commercially available. And so, Rahul is involved in a couple of these DLL3 studies. So you could be asking him, is it possible, could you get me into a DLL3 study so we can look and see if anything shows up? But we had a guy who was waitlisted with him. One of the problems is that some of these studies are for all cancers that express neuroendocrine, and unfortunately, prostate gets pushed down the list. And so there's no, the spots, there aren't any spots left for the prostate guys. We had that happen to a couple of people a couple of years ago when we were trying to get them into a DLL3 study. But I think you got to push him and say, what have you got in your magic box that we could look at? Because pretty much whatever Misha's looking at, Rahul's looking at as well. And they work closely together. All right, we're going to take these last two questions and then we're going to move on, or comments. We've got, Dennis, last one, Gary V. Gary V in Portland.
Yeah, my only comment would be: has anybody looked at the studies that are being done in Germany as of late, treating small cell neuroendocrine prostate cancer? I mean, there's some pretty fascinating stuff that's coming out of there. Uh, they are using it more and more actinium, and they're using different um, carriers than
Right.
PSMA. So, but I mean, it depends on how far you want to push this. But there are some incredible things going on in other countries right now with research into this as well as treatment, and some of the results are, from what I've read, are rather profound. So it'd be worth taking the time to take a look at this.
Well,
But I'm sorry.
I think oh, go ahead, Ben, and then I'll say say the comment. Go ahead.
I was just going to say that first Mark has to be diagnosed. He can't even get a diagnosis yet, before you can go on to the miracle neuroendocrine treatment.
Right. We don't know for sure that it's small cell. Now, the other thing is that there's very few people in the whole country that know more about what's going on across the whole of the world in certainly prostate cancer neuroendocrine than Rahul and Misha. So I feel sure that they would be aware if there's something there. I mean, you can ask him, is there anything overseas that might be better than what we got here? But like the actinium, which they're linking to DLL3, it's very hard to get into those studies. And like I said, there aren't that many spots for prostate guys in terms of the trials. If they're available overseas and you want to spend the money and you want to try, then that's a whole nother discussion. But I would agree with you. There's some really exciting stuff going on in particularly in this field, and the best places that I'm aware of are Dana-Farber, Memorial Sloan Kettering, and UCSF are probably the three best centers for that research right now. All right, I'm going to keep moving here, and we're going to talk to John Graff next. What's on your mind, John?
Hey everyone. Just status wise, I'm in a very similar situation to Eric. I had a Gleason 9. I'm going to get my first PSA test after radiation, and I did the HDR old-fashioned style in about a month. But I'm looking at, I saw a study that showed adding docetaxel early on, even before you see metastasis. It's a meta study. I put it in the chat. Improves OS from like 60% to 80% at 10 years, even without metastasis, if you do it right from the get-go. So I'm wondering if anybody had any opinion about that. And I know it's like I'm on abiraterone now, but and I'm not really excited about adding docetaxel, but if it improves and they're saying even without metastasis, it improves it. So I'm wondering if anybody has any comments on that or knows anything about that. Appreciate it.
I haven't looked at this study. I don't know if any of my guys have looked at it. I've got it up on my screen. Traditionally, there was no benefit from adding docetaxel early on. I mean, I remember asking that when I was diagnosed.
Right.
This study is already a year and a half old. I don't know. I need to look at it. Ben or Len or Dr. John, are you familiar with this study? And I mean, it's against the common thinking. It's against the common thinking.
I mean, to me, the kicker is that it says low PSA levels. So these are people who would not be thinking. These are people who would not be responsive to hormone therapy in the first place.
Good point. Good point. Good point. Good point.
Isn't there some downsides, Rick, I'm sorry to break in here, but isn't there some downsides to chemo early on that have been reported in some of the studies?
Well, in the past, it's been based on the volume of metastasis. So there's no downside if you've got a lot of metastasis at all. But they haven't seen a benefit to giving it to you if you're not metastatic. This study that was posted is for high-grade prostate cancer with low PSA levels. Now, I don't know what low means, but if you're sitting there with a 4+5 and a PSA of less than 1, and we see people like that, yeah, I could see that docetaxel might be, but again, I've got to look at Gleason scores 8 to 10, PSA level less than 4. So these are people when diagnosed with less than 4. What was your PSA when you were diagnosed, John?
Oh, it's really high, 19, but it's
So
down to 0.3 now,
yeah, but
0.03 now.
yeah, but that's, you see, these are what they did is that they put people into this study who had weird prostate cancer. And there's probably a couple of folks on this call right now who fit into that category, who had very low PSAs, like 1, 2, 3, 4, and 4+5s. And those are the people that we think might morph very early, very quickly. What was your PSA, Mark Balance? What was your PSA when they found the cancer?
1.
There you go. And
It's never been above that.
Never been above it. So Mark would have been Mark might have been the type of guy that would fit into this study. And we'll look at it. But John, it's not appropriate to you because you didn't have an unusual amount of PSA that you were making, either exceptionally high or exceptionally low.
Yeah.
Okay.
Makes sense. Yep.
Okay. So no, it's not something that's relevant to you, but I appreciate you bringing it up. And oh, it's Brandon Mahal. We know him. He's at Sylvester in Miami. But yeah, I'm saving that. I'm going to read it later. How about you, Ben? Are you going to save that one and read it later?
I don't think so. It's
okay.
a meta-analysis, and it's not really that surprising.
Okay.
Okay. 80% in 10 years sounds good.
Okay. All right, I'm going to keep moving. Steve T, what's your question?
Thank you, Rick, and hello, everyone. I had my first PSMA PET in March, which was negative for Mets, and I haven't begun treatment yet. I will soon, but I was wondering, when should I have the PSMA PET repeated?
All right. I've been talking too much. I'm going to throw that off to Dr. John, because I don't know if Len's there too. Who would like to take this one, Dr. John or Len?
I will. I mean, it depends on when your PSA recurs. Normally, when you begin to have a recurrence, you would get, as determined by PSA, you would then be considered for a rescan. Now, there is a little bit of evidence, maybe not more, maybe more than a little bit, that sometimes there's a radiological recurrence before there's a biochemical recurrence. My particular oncologist won't hear of it. He wants to wait until a biochemical recurrence before doing another PSMA PET scan. So it's up to the judgment of your oncologist.
So does the fact that I have not received any treatment yet have any bearing?
What's your PSA right now?
It was 8.52 in April.
and you're still not on any treatment.
Correct.
But that's because you haven't decided on a treatment, right, Stephen?
Well, I'm close. I've got something scheduled for the end of the month, but I'm
Okay,
All
wondering
right,
if I
I'm
should have
stumped on it. If you still haven't started any treatment, and you still haven't bottomed out your PSA, then no, I don't think that there's any reason to rescan you at the present time until something changes. The only scenario I can think of why is that if you, let's say you just decided you refused all treatment, you just wouldn't do it. Maybe sometime in the future they'll get another PSMA scan or another PSA blood test to see if things are advancing without treatment. But it doesn't sound like you're going to continue to decline treatment. You're just still looking. I mean, you're a
right.
4+5. You don't really. It's not like you're appropriate for active surveillance. So you're gonna be on treatment, and the treatment's probably gonna knock your PSA down to non-detectable. At that point, you're gonna continue treatment uh, for maybe a couple of years, and then monitor for recurrence. And when that occurs, you'll probably get scanned again. Do my colleagues agree with that scenario?
I
I
do.
would. Yeah, I would.
Yeah, I agree with that.
And Steve, what's your current PSA? You said your PSA was 8.5 in April.
Yes, and that's the most recent test I've had, although I've got an appointment with my urologist later this month, and she will have another PSA
But
test done.
you see, here's my problem. You're sitting here asking us about PSMA scans, and really what you should be doing is following up on that PSA every month at this point in time if you're 4+5. You want to know if this thing gets out of hand. Why are we even talking about PSMA scans when for $35 we can get a PSA scan if you're really concerned? There's something wrong with this equation.
We're not progressing in a couple of months. We need to see something move now.
You know, if you came back to me and said, you know what, I was 8.52, I've been trying to make a decision, it's now July, and my PSA is at 15, we might say, well, yeah, maybe you should. But we don't even know. And we're not going to use PSMA to see if you progress. We're going to use much more basic tools, which are much less expensive. And if you're really concerned, I have to say, Steve, excuse me for being forthright, you need to be on top of this. You need to be testing your PSA and see where it's going if you're taking time to make the decision. God bless you if you want to take the time. That's okay, but stay on top of it. Because the next thing we're going to find, you're going to do a PSA and you're going to come here and say, "Oh, my PSA suddenly went to 20. Oh my God!" And then we've really got to be talking. Get a PSA tomorrow.
Appreciate your forthrightness, and to get that PSMA or the PSA test tomorrow, I assume I need an order from, say, my urologist. Would that be right?
You could get one from your PCP, or they may have even put a standing order in for you.
Yeah, I bet there's an order in there already because you have an appointment coming up.
Okay, I'll look into that and get that done as soon as I can. Thank you.
Please, 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 please. Really, really important. The other thing is you have a largish prostate, so we've got to take that into account as well. You know, when we're looking at that. So I'm going to keep moving. Where's my list gone? Where's my list gone? Okay, Chuck Snyder.
Okay. I had a rough 3 or 4 months, and my situation is similar to Mark Valen's. I was on Pluvicto, which I was having a good response with, PSA went undetectable, and then so I was still just on the Orgovix for a while, a couple months, and then all of a sudden I started getting horrible bone pain in my ribs, my spine, my lower back, my hips, everywhere. So they did a PET scan, PSMA PET scan, and a bone scan, and MRI, and the cancer had spread like crazy, because before the Pluvicto, I only had cancer in the abdominal lymph nodes. So, and then it had spread rapidly after the Pluvicto to my bones, which I never really had in the past. So, listening to what Mark said, I'm kind of concerned about small cell also, because they did a biopsy of my my bone, the lower spine, the SI joint. Excuse me. And that was negative for small cell, but the chromogranin A blood test, which is you know, a good indication of small cell. Now that's rising rapidly. It went from 117 to 207 to 328. So I'm concerned. I told my oncologist, you know, I'm concerned about that, and he said that the bone biopsy is more definitive than the you know, the chromogranin A results. He said if it was small cell, you'd see, you know, readings in the thousands. But anyway, but it's still rising rapidly, the chromogranin A. But anyway, I'm on 2 chemos. I'm on Gevtana and carboplatin.
Yep.
So my fifth treatment is tomorrow. So, but go ahead.
Well, I'll come back to you because I'm really curious to hear how you're tolerating that. Did they do, when they did the last PSMA? Well, let me step back. You had a lot of pain. They did more tests. You said they did another PSMA scan and they saw a spread on that. Is that right?
Yes, correct.
And did they do an FDG PET as well?
They did not, and I did question my oncologist about that, and his response was, the PSMA, you know, the PSMA scan was showing significant metastases, you know, throughout my bones. So he thought it was PSMA avid metastases. So for that reason, he didn't think FPG was necessary.
Well, the reason I would say an FDG is necessary is because if we see it also in a bunch of places where we don't see the PSMA, that would start telling us that maybe there is something going on. So I'm not saying that you're not PSMA avid, and maybe Pluvicto could help again. Did you get 6 originally, or did they hold any back?
I did 6. Actually, I started with 4 rounds, and I had such good response. You know, the PSA just went undetectable, and I took, you know, a break from it for a while, a few months, or I can't remember, maybe 3 or 4 months, and then I got back on it and finished the last 2 treatments because the PSA started to rise again. But
so a couple of things that come to mind immediately. One is who read that biopsy for you?
Who read it? I had it done at NYU, Langone. Somebody from NYU.
Okay, do yourself a favor and send it to either Epstein or Zhao, and ask them what they see in it. It's not going to be very expensive. It's covered. They're both in New York City. They both know us very well. And we would strongly suggest that you send them out and see if they see something that the NYU pathologists are not seeing.
Could you repeat that again? Epstein? What's Epstein?
Epstein and Zhao. If somebody can put them in the chat window, the contact details for them, I'd appreciate it. But they are the two best eyes in the country, in our view, for looking at these cells.
Okay.
Stein's up at Mount Sinai and Zhao's up at Mount Sinai, and Epstein's in advanced something or the other. He's in his own practice. He used to be at Hopkins for forever and a day. So we can. John's put in the email address for him, but if I'll see if I can put in some more. But that's certainly the first thing that springs to mind for me. If you've got a recent, the problem is, like I said to Mark, just because you don't see it in that place doesn't mean to say that it's not in another place.
Right.
When was the last time you were sequenced?
I'm
You
sorry,
had
what do you mean by
when
sequence?
was the last time they did genomic somatic testing on you?
I just had that recently, a few months ago also, and they didn't really find anything from that. I'd had a repeat of that done, I'd say February. Yeah.
Okay, and they didn't see anything new. What mutations do you have right now?
I don't know.
Okay, because that's important. Does RB1 or P10 or TP53, do any of those sound familiar to you?
Yeah, I'd have to look at the report. I don't recall. Yeah.
So because that becomes a factor. You still seeing David Wise?
Yeah.
So we've had some experience with David Wise recently. He's pretty good, and he's very he is responsive. So I don't want to say anything bad about him at all. But at the same time, you got to be looking. I mean, how about somatostatin? Did you test somatostatin?
What is that, a blood test or what is that?
It's a marker that shows up on small cell neuroendocrine cancer.
I'm sure I probably had that done. I have so many blood tests done. Let me write that down. Could you spell that?
Oh, Ben will be kind enough to put it in the chat window for me, and as soon as he's done it, I'll call on him because he's got his hand up. So, because I'm trying to get the more than Dr. I'm trying to get Dr. Zhu's details for you as well. So here's we keep putting his email address in, but here's oh no, that's no good. Zhu. Okay, copy. Here's a website for Zhu as well. And they know us. They'll talk to you afterwards. They're good people. Ben, since you're helping me so much and you have your hand up, I'm going to call on you.
Oh, so it's the somatostatin. That's the blood test. Yeah.
And we can't hear you, Ben. All of a sudden you've gone, what's happened here?
Okay.
Now we got you.
Chuck, I'm really sorry about the new Mets. As far as I know, the point of chromogranin A is not the absolute level. Different people have different baseline levels. The important thing is that it is rising, and that seems to me to be a pretty clear indication. However, if you're getting cabazitaxel and carboplatin, you're already getting the treatment for neuroendocrine cancer.
Yeah. Yeah.
Yep. And how are you responding to that? Because that's the treatment that has been recommended for Mark.
I was in such horrible. I never experienced such horrible pain in my life from the bone pain, but the chemo really, I'm completely eliminated the pain, and I'm off all painkillers, and but so yeah, I'm responding well to it, but I don't know, once I stop it, what's the next step? Clinical trial. There's not many options. Another thing is my blood work is so, the red blood cell count is so low. I ended up needing 2 blood transfusions. So that kind of disqualifies me for clinical trials, because I guess you need a red blood cell count of 8 or above. So mine was below that.
I think you mean hemoglobin, Chuck?
Yeah, hemoglobin. I think it's hemoglobin. Yeah.
Did the transfusions bring up the hemoglobin level?
It did, and then it lasted for about 7 weeks. Then I needed another one. So seems like every 7 weeks I need to get a transfusion.
Okay, I'm going to suggest one last thing, then we've got to move on. I think you should make an appointment to go up and see Dr. Misha at Dana-Farber.
Uh-huh.
And if you decide to do it, let me know or let Ben know, and we'll give her a heads up, because she may have some stuff. It does sound like you'd be a candidate for some of the stuff she's doing. She's terrific. She looks like she just graduated high school. I'll just tell you right now. But she's so smart, and this is really her field. And you're on the East Coast, so we can't send you to Rahul. But let me just put her. It's Misha, M-I-S-H-A or M-I-S-C-H-A. I can never remember.
Himisha, H-I-M.
Well, that's her full name, but that's her formal name, Hamisha. But she does go by. Here you go. I'm gonna put it in. She knows us pretty well. There's her right underneath Himisha Beltran is her details. Give her a call. She's sometimes hard to see. Use the AnCan name. Say AnCan sending me, and try and when they say, please tell her that I'm an AnCan person, and see if you can get in to see her. And it would be worth a trip up to Boston to see her.
Okay. All right. Thank you. Appreciate that.
Okay. And please download the chat, everybody, if you want what's in there, because when these long posts go into the chat, I don't have room to put them in. I'm restricted in how many words we can put on YouTube, although I can fully copy the chat on the on our website, but I can't put them all onto YouTube. That's the problem with these with the long posts. I have a 5,000 word limit on YouTube. All right, we're going to keep moving along. George Diaz, you have a question.
Yes, it's hello everybody. Is there a reason why you would want to have a rectal biopsy as opposed to perineal? In other words, is there an advantage to a rectal biopsy?
In one simple short word, no.
Okay, thank you.
We know now and the urologists are slow in adopting it, but it's getting there. But we know now that the complication rates and the infection rates are definitely higher in transrectal, plus the fact that with transperineal we can see more. And we can see some occult, some hidden areas in the front of the prostate, which are very hard to see with transrectal. And so disease can hide in transrectals, and it's much harder for it to hide with a transperineal.
Okay.
So those are two very good reasons why we recommend to everybody that if they can to argue for a transperineal. Some of the urologists will tell you, oh, it doesn't make a difference. That's not true anymore. The research is there. If I can find it, I'll put it. I'm trying to remember the name of the research trial that just came out, because that's where I've got it. But let me see if I can find that for you. So why do you ask, George?
Well, I saw Hellfan.
Yeah.
And he ordered a germline test, which
right.
I just had done.
Right.
And he wants to do another biopsy and another scan.
Okay.
And he suggested a rectal biopsy, which perplexed me for the reasons you cited. So, you know, that's where I am. He also suggested nano knife, because my cyst is confined to the prostate. It has not spread. You know, as you know, I have IDF. The decision has not been made yet on the nano knife, but he suggested it. He wants to take a look at another biopsy, which I will probably send to Epstein. Epstein requested that be done.
Okay.
So
George, let me interrupt you. I've just posted for you the PREVENT trial. You can send a note to Hellfand and says Howard Walensky says no transrectals with a smiley face, because he knows Howard really, really well. He knows us really, really well, and he might be able to sell it to some of his other people, but he's not going to be able to sell it to us. And there is a big difference. And you should be doing a transperineal, and no ifs, ands, or buts.
Well, again, he's suggesting
send him the PREVENT trial. Send him that trial that I just posted, which is out of JAMA, which was published in JAMA just recently.
Okay, very cool. I will. And I was frankly perplexed for the same reasons you cited. And again, he mentioned briefly the nanoknife procedure.
Well, nanoknife is SBRT, okay? Nanoknife is SBRT. There's a lot of cyberknife, nanoknife. There's a whole bunch of different ways. And it's just a type of high-powered radiation treatment. And it's basically whatever they have in their shop, because that's what they push. But it's not a different, it's no different from somebody talking about SBRT. Well, I would say that talk about it with Dr. Mark next week, because he's the expert on all the different radiation therapies. He really knows them well in the low intermediate, and he'll tell you if nanoknife is better or worse. I don't know. I'm not sure if I know. John and Len don't have that knowledge. Ben, do you have the knowledge on the difference between the high-powered? the person in our group who has that knowledge and can talk to it and stand up and do a lecture off the cuff is Dr. Mark Perlow. He really knows that stuff. But don't get wooed by terms. NanoKnife is SBRT, and it's probably a good option for you. But we know you have these complications with your diagnosis with the intraductal, right?
Yes. Yes.
So so that's what I would do. No, probably nothing wrong with another. But when was the last time you had a biopsy?
3 months ago.
I mean, I would be
began cooking.
Right, and that was a transrectal at the time?
No, it was transperineal at Northwestern.
Okay, well, I would be asking Dr. Helfand why he thinks he needs another one right now. What's making him suspicious? What's he looking for? Have you seen Egner yet or not?
I have not, but I will.
Yeah, I would go see Egner. Ben, you got your hand up.
So just to fill in the perspective here, George has had only a single core positive of however many cores were taken, and that core had this dicey intraductal. So it seems really important that he get a different or a second biopsy, because why is there so little of it? And it may well be that Helfand, who I guess is you're now getting this in Chicago. You're not going back to the same guy, George, who gave you the first biopsy.
Correct. I'm not. I'm not going back to Northwestern.
Good. I mean, the reason he may be suggesting now a transrectal, if the first one was transperitoneal, is exactly for this reason, that clearly they missed something the first time. Maybe they need to go at it literally from a different angle.
Yeah, I mean, I think in that circumstance, I definitely would be talking to Egner and see what Egner thinks.
Okay. Well, that's good. Yes. Thank you. Thanks.
Okay. All right. Who's next? Wes is next.
NanoKnife isn't SBRT, Rick. It's electroporation.
Oh, NanoKnife is electroporation?
Yeah.
Forgive me. Where's my man Stuart? Is he still on or did he leave? He must have left. That's what Stuart had, electroporation.
Okay.
Thanks for the correction, Jeff Marchi.
Sure.
That's why I don't moderate the low intermediate group. That's why I'm in this group, where I tend to know a little more about what I'm talking about. I didn't realize NanoKnife was the same as electroporation. So again, electroporation, now I see what he's saying, is a type of focal treatment. I don't know whether, I don't think you should be doing focal treatment, George, with that intraductal disease. And again, challenge Helfand and say, why would I want to do focal treatment? I mean, it's a shame Stuart left, Stuart Jordan. The Stuart's in that Retire study where they combine electroporation with radiation of the whole gland, which has been a very successful treatment to date. And thank you for the correction, Jeff. Yeah, I mean, I'm not a huge fan of focal treatment, and definitely not for somebody who's got the level of disease that you have. Well, I'd be wanting to get a second opinion.
Yeah. He appears to be moving in that direction, but I presume he doesn't. We don't want to decide until he does that second biopsy, for the reasons that Ben cited.
Okay, and again, it isn't necessarily him alone who should be doing he's not the only one. I mean, I originally, yeah, Healthan's good, but I would rather see the people at University of Chicago. We got to move on. Sorry.
That's okay. Well, and I appreciate that. Thank you.
Okay, Wes, what's on your mind today? Are you with us, Wes? Yes, you are. There you are.
Short update.
So I can't see your mouth. Oh, there you go. No, we can't hear you. We could hear you before, but we can't hear you now. All right, I'll tell you what. I will come back to you in 1 second. Let me just put something in on that suggests. No knife. I'll come back to you in a second, Wes, but we can't hear you, so we need to get to hear you first. Steve L, you wanted some time. Did you get yourself sorted out with your sound today?
Yes, I actually was on the road when I was talking earlier.
Okay.
Yeah, quick update. Finished my radiation therapy on June 17th. Had gone castrate resistant in April 2024, and my PSA had risen to 1.07 in March of this year. And after the radiation treatment, I did a PSA July 1st, and it was 0.28. So everybody's pretty happy with that movement.
What date was that again? That it was 0.28?
July 1st.
Oh, okay. All right. So what about you? Never mind everybody else. Are you happy with it, Mr. Lodge?
I am. And yeah, no, I am happy with it. And yeah, we'll follow it for a while and see how it goes.
Okay. And what treatment are you on right now?
Well, I'm continuing with Lupron and abiraterone, now with dexamethasone.
Okay. So basically what you've been on before. That's a good report. Anybody have any questions for Steve L? I'm going to move on, Mr. L. Looks like you're short and sweet, and it's a very positive. What was one last question? What was it before you started this last round of treatment?
1.07.
Okay. Okay, and I'm sure Larry Fong is very happy too.
Yes, he is.
Okay, all right. Steve L. Successful treatment. All right, next is back to Wes. Wes, can we hear you this time?
Okay, how is this?
Great.
Excellent. So I'm halfway through 28 radiation treatments focused just on my prostate. Started Orgovyx for 6 months. And the interesting part was that, no test is really absolute for diagnostic from what I've learned. So going back and forth, PSMA, MRI, that excluded seminal vesicles, other things, neck, cervical, and the radiologist, very pleased with the guys at San Diego UC, Liss, Siebert, and Randall, surgeon, radiologist, and oncologist, seemed to do a very good job, and they listened to me very well. I wanted a minimal treatment. Yes, I have 4-3. Criviform, intraductal, yes, it may come back. We'll see in 6 months how everything goes.
And how are you managing with your IMRT treatments?
Well, I'm starting to see that they do create issues. So I have a little more trouble peeing. My prostate was 26 cubic centimeters, so I never had trouble before. I have more empathy now for other folks. There's no pain. There's a little discomfort in urination. Masturbation doesn't work very well. There's a discomfort, but I usually refer to all this as first world problems. Because if you're going to pick at mine, yeah, it wasn't ideal, but it wasn't horrible compared to a lot of the guys on this call or certainly other cancers. I do sleep 10 hours a night. I'm probably as concerned. I'm probably more concerned about the hormone therapy than the cancer, to be honest.
Okay, so let me catch up with you a couple of things. Liss Siebert, and who was the other one?
So Liss, Liss, is the surgeon.
Yep.
Siebert is the radiologist, and Randall is the medical oncologist, all in urology, all PhD MDs, solid guys.
Yeah, I don't know Randall. Liss knows as well, because we just did a has he got you eating 30 vegetables a week?
Oh well, just tell him that. Yeah, the geologist showed up on AnCan. I refer to myself as not very medically trained, but I do ask a lot of questions.
Well, and I don't talk him, but he did a great webinar for the AS folks a while ago, and we tried to recruit for him for his trial. He's a really good guy. I like him a lot. So you can tell him next time you see him that AnCan says hello. And
I definitely will.
Yeah, I think we sent him a T-shirt.
One take home for everyone here that I learned. So I do geology, geophysics. So all this radiation is similar, sort of a step over in some fashion. And way back in Navy days, I was a radar tech on radar. So anyhow, I know some aspects. But what I speculated and Siebert confirmed is that you cannot compare one MRI to another, even in the same facility, much less from one facility or machine to another, because it depends on the machine, the calibration, the technician, and the specifics that the radiation guy wants to set up. He has a journal article that says that out like 2 years ago. And so they're working for some sort of standardization, which seems appropriate. The second was that my PSMA had, like its characteristic, maybe 60% accurate, both positive, false positives and false negatives. It beats not having anything, but in my case, we spent quite a bit of time, couple of months, going down the path of trying to rule out the false positives, which really changed my treatment from overall pelvic, potentially lymph nodes, seminal vesicles, and so forth, to much more focused on the prostate, even though, like I said, I had a fairly aggressive looking biopsy.
So Wes, this is John. Excuse me, Rick. So you did have some low SUV fuzzy places in your body, but I kind of had the feeling that you were non-metastatic. Your radiation therapy that you're getting now, so I understand, is either all to the prostate or all to the prostate and the pelvic and the pelvis.
No,
is that
the former.
Correct?
Yeah, Siebert's take was the same as yours. His PSMA is a little fuzzy, so he got a high resolution MRI, which he does in order to focus things. And he said he didn't see anything, had the radiograph MRI read by other people. No one saw anything. He goes, that's just not the way you would expect it to be. So he focused everything on the prostate itself and left everything else alone, which seemed rational to me.
And including the cervical spots that you were concerned about?
Yeah, cervical, we had another MRI on that, read by a couple of people, and they said no, they didn't see anything. So that was huge. That's huge.
That's
So
great
are
news.
we happy? Are we happy with Wes getting treatment strictly to the prostate? There are no even local lymph nodes at all, but he's a 4+3. So I guess the question in my mind is, does a person like that get also radiation treatment to the local lymph nodes, or is that completely unnecessary because his disease is restricted to the prostate?
You know,
Yeah, I
according
mean,
to
if there's no evidence of anything outside the prostate, then that's the right treatment. And what
And
he
we
did
do it.
is,
Okay.
yeah, and so they did a great job. Sounds like they did a great job at UCSD, I have to
Yeah,
say.
and John, and like I say it to people, I'm a different kind of personality. I don't care to be living to 90 or something. I want to be treating this as efficaciously as we can. I want to be having a holiday after 6 months, even though I realize my prostate cancer probably will come back. I mean,
Okay,
that would
so
be my money
I'm
bet.
gonna keep moving along because we've
Thanks so much,
really got a
Greg.
bunch more people, and we're almost at 7 o'clock already. My time, your time, it's even later. So, John McPhee, what's on your mind?
Can you hear me?
We can hear you, yes, sir.
So I was treated in late 2020, sorry, late 2020. I had SBRT to the whole gland and high dose brachy to and focal therapy to the side of the gland that had cancer. And in January 24, my PSA popped up to 2.5, and they said, "Oh, it's back, we think." I had a PSMA PET scan, and they said it was inconclusive. I had MRI a little bit later that went along with it, and they said, "Yeah, maybe, but it's still not sure." Now, 18 months later, my PSA is up at 17, which is a doubling time of less than 6 months. And when I talked to the radiation guy, and he says, "Oh, I want you back on Lupron," and I had a bad time with Lupron. My muscles didn't matter working out with weights and stuff. My muscles just went away. It got so I couldn't get up from a deep squat without pushing myself up on with something or with help from the floor. And so I didn't want ADT. And he said, "Well, if you don't like the side effects of ADT," he said, "you're not going to like the side effects of more radiation." And so, is that it? Lupron for life? Now, a shout out to PRCI, Prostate Research Institute, Cancer Institute. I contacted them, and the guy sent me back a 10-page letter giving all my options and stuff, and just stuff to consider. And I've had nothing like that from anybody here in Ontario. I'm Mickey Mouse outfits. And so my question is re-irradiation a possibility, or is this kind of something to stay away from? Or how do I explore this further?
Okay, so let's go step by step. What is your latest PSA?
17.
17. So it's gone from 2.4 in January of 24 to 17. And when was the last time you got it measured before the 17?
I get it done every 3 months, and I have a bunch of ones before it. It was climbing quite rapidly, and then it went 16.8, 16.17 16.9, something like that. So it kind of leveled off for 3 months.
Okay, so it's been leveled off around 17 now for a few months. Is that right?
Yes.
And when was the last time you had a PSMA scan?
It was in January of 24.
Well, you need another PSMA scan.
Yeah,
I realize it's in
what I got was
Canada.
a bone scan.
Yeah,
It
well,
showed no Mets, but not
Yeah,
used.
you need a PSMA scan, John.
Yep.
And without that PSMA scan, we can't determine what treatment to do. Maybe you need hormone therapy. Maybe, I mean, if you could convince them in Canada, and I don't know if you can, to give you a monotherapy without the Lupron, that might be a way to go for you too. But there's probably some metastasis that needs radiation. You're probably oligometastatic. We need to see where those spots are.
Okay, I've made in the last couple of days. I've realized that I can't depend upon these quote centers of excellence unquote to take care of me. I got to drive my own bus here, and so I've put in calls to Sunnybrook and to my local hospital to either recommend me or get a PSMA PET scan and
Well, I don't know the rules in Canada about how often they can do a PSMA and on what basis. I know what they are here in the United States, but the fact is that you clearly need a PSMA scan.
Okay.
And if you can't get it at Princess Margaret, then yeah, you're gonna have to go over to Sunnybrook and see if Sunnybrook will do it for you.
Yep.
You clearly need a PSMA scan. That's your starting point. I mean, PCRI can send you great information, but we don't even know what's relevant until we know what you've got. Doesn't help you.
Okay. Yeah, and then followed by a biopsy because it's on the side that didn't get the HDR treatment. So much for focal therapy.
Well, which focal therapy was it you got?
I got the full gland SBRT and high dose brachy on the half of the gland that had the cancer.
Yeah, but that's not focal therapy. That's not focal therapy. If you got SBRT plus high dose radiation, that is not focal therapy. They treated the whole gland. Don't feel like you got shortchanged. You didn't. Focal therapy is something totally different. You got the whole gland. What's happened is you got it, and like 35% of men with prostate cancer, it came back, and that can happen. I have notes that you got 5 sessions of SBRT plus HDR. Now that sounds to me like it was in a trial, and the 5 sessions of SBRT was across the pelvic girdle, because you wouldn't get SBRT and HDR all to the gland. That would be really unusual. So they were probably doing some sort of a trial with that SBRT.
It was a trial, and my understanding was the trial part was they only, in fact, the guy wrote that the high dose brachy was to the tumor and not to the other side.
Well, that's what they do with high dose brachy. They tend to do that. That's exactly what they do with brachy. They just treat where it is, and then they also treat, in your case, the whole of the pelvic girdle.
Right.
That's the standard of care. But I think at this point, whatever they did wasn't bad. I mean, I don't feel like you should feel that they didn't do the treatment. Now the follow-up is different. I don't know why Chung, if you're still seeing Chung, why Chung is not willing to give you a PSMA scan right now. That's the starting point.
Yeah, I don't know.
I would call him up and say, Dr. Chung, or send him and say, Dr. Chung, what can I get a PSMA, please?
Yes, I've contacted the nurse that I contacted, and she sent an email the last 2 weeks, and I'm waiting for a response.
Well, again, I can't help you navigate, but I think you got to push him. PSA of 17 needs attention quickly, and you need a PSMA scan.
Followed by a biopsy?
No, you don't. I mean, why would you need a biopsy at this point?
Does being on Lupron affect the PSMA scan?
Yes, it may do. I wouldn't start I wouldn't start the Lupron until you have gotten the PSMA scan.
Okay.
If it were me, I
And,
would not.
and is Casodex as effective as Lupron?
Casodex is required before you do the Lupron to ensure that there are no adverse effects from the Lupron. That's why they're giving it to you.
Right, but
They're giving it to you. You don't want to take that Lupron before you've done 10 or 15 days of Casodex.
Right. Can I stay on Casodex?
No, that doesn't measure up. That's a very poor, very old form of therapy. What actually happens is that you have this miraculous recovery that when you stop taking the Casodex, your PSA goes down because the Casodex is turned into an agonist that makes the androgen receptor get worse instead of better.
Okay.
So there's your answer, and you may need to be on a second. You may need to be on a second, or you may try and convince them that you just want to go on a single, like enzalutamide or abiraterone alone, without the other one, if they're willing to do it. Again, you've got a different system there, so it's very difficult to get these variations on the treatment. But I would say for the time being, come back. Don't stay away. The last time we heard from you was 4 years ago.
Yes.
So come on back and let's try and help you get this PSMA scan.
Okay. Thank you.
Anyone else for John before we move on? All right. So it's 7:03. I'm going to tell you exactly where we stand. We still have 1, 2, 3, 4, 5, 6, 7, 8 people, and I will stay here as long as it takes. So if you are going to drop off and you ask for time, please put a note in the chat window so we know to come back to you next week. Thomas M., what's on your mind today?
Yeah, I had an agenda for today, but I'm just going to cut it down to the bottom line for right now, and then continue next week. I have had a recent DEXA scan, and my osteopenia has morphed into what they say is an osteoporosis condition because of the standard 2.5 standard deviation, etc., which I don't understand, and I'm going to have to talk to somebody about that. But my question is about the treatment. So they're suggesting Zometa or reclassed, and I've looked at my meeting notes, and these items have come up, and people have made commentary about them, and it just seems that based on the AnCan meetings, that people are saying that the denosumab is better, and I don't know what that means from my notes, but people seem to prefer the denosumab, or somebody has recommended that over the Zometa. So can anybody comment on that, please?
Who'd like to take that one on?
I'll give it a shot, Rick. I don't believe that denosumab has ever been proven to be more effective than Zometa. There might be some people who have more reactions to Zometa than they do to denosumab. But as far as effectiveness goes, I'm not aware that there's any difference in effectiveness. In any case, you shouldn't be on any of those meds for more than 5 years, because you increase the risk of osteonecrosis of the jaw, which is kind of a disfiguring side effect. So I think it's just more convenient to get the Xgeva. It's a shot. It's an intramuscular shot, whereas Zometa is an infusion. So that's something to consider.
Anyone else want to comment before I?
Hey, Len, how about finishing it off with Zometa, like you were talking about?
Yes. So I was on Xgeva for 4 years, and I was starting to get concerned that maybe if I stayed on much longer, I might get that ONJ. And so there was a paper published saying that if you can safely discontinue denosumab or Xgeva, if you once you stop it, you get a one-time infusion of Zometa, and it will lock in the gains that you made with the Xgeva. That seemed to work for me. I did that, and my bone density remained at a pretty good level, the same level that I had when I stopped Xgeva. Now, I did have a reaction to the Zometa infusion of violent shaking chills, which lasted for several hours in the evening following the infusion. However, I don't believe that's very common. But it did surprise me because I've never been allergic to anything. But anyway, that's just anecdotal. I wouldn't steer anyone away from that based on my experience.
So I've just put in 2 references that I have on denosumab versus Zometa for treatment of bone mets, which is different from what you're talking about, Thomas, because you're talking about an advancement in your bone density. So they may not really be on target. I am not sure. I'm not certain that there hasn't been a comparison. Denosumab hasn't found to be superior. In the back of my mind, I don't want to argue with them, but in the back of my mind, I do think I have seen it because I got zoledronic acid, I got Zometa myself for the same reasons you're looking for it, that I was osteoporotic. And I'm pretty sure since that time I've read that denosumab is considered to be a better drug, but I'd need to do the research to find out. So, for me, the jury's out. If I had my choice, I would probably do denosumab right now. In what form, I'm not sure, because you can get it in Zometa, which is an infusion. In my case, I got 3 treatments over 2 years. Normally, if you have Mets, they'll give it you once every 3 months. So I don't know. It's all a question of which one. Now, it's all a question of what your docs are saying, which one they give you.
Rick, can I just interject here? I'm sorry. I wasn't aware that Thomas was the only reason he was doing this was for osteoporosis, in which case then I would, well, I know we're not supposed to give medical advice here, but let's say if it were me in that situation, I would go with Prolia, which is a lower dose of denosumab, and you only get it once. It's half the dose, I believe, and you only get it once every 6 months instead of every 3 months with an injection. So it's it's very convenient.
Right.
Okay.
That's what I would do too.
Okay, that came up in my meeting notes. This kind of discussion is kind of being recycled a little bit, so that's good, and I'm really glad you brought that up, Len. And I've got a little confusion here about something Rick said. Let me just understand that these Zometa and something called reclassed are both zoledronic acids. And the denosumab is Prolia and Xgeva. Prolia is the low dose, Xgeva is the higher dose.
Correct. Right.
Okay.
Gary Peters, what's on your mind?
I'm in my, I had osteoporosis, and I'm in the middle of my 4th year on Prolia injections. And I'm doing better. I'm going to be meeting with my doctor in a couple of days to go over my latest test, but I haven't had any issues and I'm doing better on the Prolia.
Thank you, Gary.
Okay. So, I think that most of us in this group with your situation, if we had the choice, would ask for some form of denosumab rather than zoledronic acid.
Yeah, I agree.
It does have a slightly higher incidence of the necrosis of the jaw than zoledronic acid.
Okay.
That's why my oncologist had me on it, because of the necrosis, higher likelihood of necrosis. And Zometa was better.
Okay. Thank you. Thank you very much.
Okay. Keep moving right along here. And the next up is Steve White.
Yes, hi, Rick.
Hello.
Thanks for staying so late. I just wanted to give you an update tonight on since the meeting I joined about a month ago.
Yes.
So you had encouraged me to move from a local radiation oncologist to one of the universities. I reached out to both the doctor at Duke that you suggested, Hannah McManus. She's actually on maternity leave for the next few months till November. The UNC Multidisciplinary Cancer Center was available. I met with them, 2 doctors, Dr. Wijatunga, who's the radiation oncologist, and then Dr. Tracy Rose, who's the medical oncologist. I had a very positive impression of both of them. So they've scheduled me for a PET CT scan on Friday, and they talked about the potential of doing radiation for my PSA is still at 0.14, and they said that they would recommend radiation looking at the prostate bed, depending on how the PET scan comes out, but prostate bed, lymph nodes in the pelvis, and then hormone therapy. So they were, those were the things that they are considering, and they want to see what the PET looks like on Friday, and then go from there. So I was very encouraged by just the clear quality of care that they seem to offer, and so I appreciate you encouraging me to move from the local radiation oncologist to one of them. So that's the quick update.
Okay, so the Tracy Rose was the GU med onc, and who was the radiation oncologist?
Neil Wijatunga, Wijetunga.
Okay. Don't know either of them. What type of radiation are they talking about doing for you?
I don't know that we talked at that level. It was more just kind of laying out the different options of the prostate bed only, or prostate bed plus hormone therapy, or adding to that the pelvic lymph nodes. They cited some studies, the sports study that talked about the increasing success rate as you broaden the scope of it. And so we talked at that level, not the specific type. But if there's specific, questions I should ask, or things I can go back to them with, I'd be eager for your suggestion.
So let me just recap here. You had an RP in surgery in 2016, right? So
Yep.
we're looking at recurrence.
Yep.
If it were me, I wouldn't do anything less than radiating across the pelvic girdle, because just from pure anecdotal experience, when they only do the pelvic bed or they only do the rabbit's ears patterns, we see the guys coming back. What is it they're suggesting that you do?
What I understood, and I may not have focused enough on the delineation between the prostate bed and the pelvic girdle, but what they said they were looking at is the bed plus the pelvic lymph nodes.
Yeah, so that's
in the radiation.
Okay, that's great if they go right across all the pelvic lymph nodes, which is great. That's what I would do. If they do this rabbit's ear pattern, I wouldn't do it, which is like 2 rabbit's ears on either side of the pelvis. And so I think you really need to do that. And I've read some of these studies. I can't quote them off the top, but at the end of the day, the pelvic bed, the whole pelvic girdle does definitely seem to be better. Steve, yes. What are they talking about in terms of hormone therapy?
They said that they thought, based on the shape I was in, that I may mispronounce this, but the pill form of Relugolix is
yes, Orgovix, Relugolix.
So they said that would probably be what they would recommend, just because of the fast uptake, and then at the end the recovery from it. They thought that I would probably tolerate that well, so that was kind of what they were leaning towards.
And were they going to add abiraterone or not?
Dr. Rose mentioned that, but she talked more about this. Let's say I don't know how to pronounce it. Relugolix.
Relugolix, yeah. Orgovix. Orgovix is easier to say. I mean, the thing is, and again, look at that download. But the standard of care is to add abiraterone today. Has Ben abandoned me?
I have not. I have not.
Oh, you have not. You just turned your picture off. Ben, isn't the standard of care? Doesn't the standard of care on recurrence call for abiraterone today?
Is this what we were just looking at? I thought it was for very high risk only.
Yeah.
I think it's for very high risk only for primary treatment, not for recurrence.
Right.
And if it weighs on it, my Gleason was 4+3, and my Decipher was 0.67.
When you recur, and I guess I can look later. I can't do it right now because it's too complicated. But when you recur, it's different from to begin with.
Mm-hmm.
And Ben's absolutely right that we, like with Ed Lafrance, who was with us, I know he still is. We looked at him and he said, and for him, for starting off with treatment, you have to be very high risk. But when it recurs, which is your situation, I think abiraterone is standard. Where I think the problem is we're not really seeing anything. I mean, you did a PSMA at 0.14 in June. Why do they want to run another PSMA now?
It wasn't in June. It was in October.
Okay. So, because I have a note here that we have a PSMA from June of of 25,
let me
was
here.
negative. Was that June
Let
of
me
20?
confirm that. I got it right here.
Okay, but was that June of 24 that you had it?
No, it was October 16th of 24.
Okay, all right.
And
So I was,
so they were saying they wanted to get another
yeah,
look at it, right? Because it's been
yeah,
6-7 months.
yeah. No, I think that you do need. I didn't realize. I mean, my notes were just wrong. But your PSA hasn't moved. It's still at 0.14, correct?
Correct. They tested it when I was there, like say, a week and a half ago, and and it was still 0.14.
All right. Well, fine. I think yes, definitely a PSMA scan. I think the only question is, do they add abiraterone or not? And if it were me, I would do it now because I go all in to try and nail it. I just have to look and see what the standard of care is.
So will you reach out to me with that, or is there a place I can look for that?
And guys, Bruce, with respect, I can't read what's in the chat window. How can I read what's in the chat window when you see me talking, man? Please.
Sorry about that.
Yeah, thank you. Is there anything you can read? Yes. Do you have the reminder? Do you have the reminder from last week?
Yep.
So
you talking to me?
No, I'm talking to Steve White.
Oh.
If you go to the top of the chat window, Steve, somebody right at the very beginning, Richard Fisk, and I'm just going to pin it right now. So hopefully,
NCCN.
Yes,
I have that up. I've got that link up right here.
Now, in addition to that, you've got the patient version, which the link was correct for the patient version, but I haven't read that through. If you look at those for recurrence, it'll tell you, and that's what I'm going to look at, exactly whether abiraterone is recommended on recurrence, and if so, under what conditions.
I've got something here, Rick, that from ASCO Pubs about the if it's under 0.2 after recurrence for salvage radiation, the patients treated achieve a higher rates of undetectability post SRT and improved 5-year. If it's between 0.2 and 0.5, it's still effective, particularly for patients with low risk features like Gleason less than or equal to 7, slow journal oncology depends SRT before PSA exceeds 0.25 to preserve curative potential.
Okay.
And then 0.5 to 1, that's when they call for ADT, but not abiraterone. And they say at 0.5, salvage radiation remains beneficial. They require combining with ADT.
Okay, so I will take a look. I'll look and I'll get back to you. And if you're asking where to look, you want to look in those NCCN guidelines.
Got it. Okay, I'll go through that. Okay, it's terribly helpful to all here as support and resource, and very much appreciate it.
It's a pleasure. Anyone else? Ben, do you want to say anything else? You got to stop mute. You got to unmute.
Yeah, I'm about as helpful either way. Yeah, I was just poking through the guidelines, trying to straighten out that abiraterone question.
So we'll between Ben and me and Jeff Marchi, we'll figure it out, and we'll let you know. I'm putting a big asterisk. Check guidelines, and we'll get to it and try and help you out with that. Okay.
Wonderful. Is that via email, or you have what you need to contact me? I think.
Yeah, I'll email you. Now, what I would say is that if I had a choice, I'd ask them to add abiraterone.
Okay.
If I had a choice, okay, but that's up to you, and if you can get your insurance to pay for it. Also minus happy. All right, keep going here. Keep going. Keep going. Next on the list is Tim in Fairbanks. Yes, Tim in Fairbanks, you're still with us. You're on the phone. What's your question? My Irish friend, are you there? Okay. Well, we called on him. Barry, are you still with us?
I'm still here.
Well, God bless you. How did you do with your appointments? You just muted yourself. I don't know what you did, but you just muted yourself.
Oh,
now you're
sorry.
good. Yes.
Okay, so first I have to send greetings to you and AnCan from Dr. Heath at the Mayo Clinic and
Yeah.
from Dr. Antanarakis from the Masonic Cancer Center at the University of Minnesota. And I was able to see both of them, and they have basically said that they're more than willing to continue to consult, but that they think the game plan that is in place under Dr. Kwon is appropriate, and that they would come in to, if things don't go as well as they had hoped, they have the special sharpshooter skills to maybe pick off something else. So appreciate that referral to talk to both of them. I was highly impressed with both of them, and so that was good. And the other thing is that you know, as we talked about a little bit before, my PSA had gone from about 8 or 9 up to 347, and I just had a PSA test at medical oncology, and it's dropped to 26. So, and that apparently is from the Firmagon shots that they gave me on the 12th. So that seems good. And now I start on a Lupron shot coming up here on the 15th, and abiraterol, or whichever one, whatever that is.
Abiraterone.
Yeah. And so I guess the chemotherapy commences, and we'll find out how the battle goes.
Okay, so there's a big difference here to what we talked about before, which is the abiraterone. So when we talked before, you told me that Kwon only wanted to do Lupron plus chemo. So when did abiraterone come into the discussion?
So they did do a genetic test, and it kicked up I think it's called a CHEK2 and an RB1 or something like that. I am
Okay.
scheduled to go back down to Mayo and meet with their genetic testing people, whatever it is, in August.
Okay.
But Dr. Herchek, I think his name is, at the Minnesota Oncology Center, he's thinking that because of those two genetic markers or whatever they are, that what Dr. Kwon had recommended, which is kind of the triple attack, was a good path to go forward on.
Okay. I mean, the
And
triple attack is good, but our problem was that Kwon hadn't recommended it. That's why we wanted you to see Heath and Antanarakis. He'd only recommended Lupron and chemo without the abiraterone.
so what's the chemo part?
So chemo will be docetaxel, which is an infusion, but we couldn't understand why he'd only said to you Lupron plus the chemotherapy. What about the
Oh,
abiraterone?
yeah. So, I mean, is that the Terrafoxil or whatever it's called? That's the chemotherapy I think I'm getting. Where's my note here?
So the
Um,
chemotherapy is docetaxel.
Or Taxoteres, right?
Carboplatin, you mean?
Taxotere,
Carboplatin?
yes.
No, Jeff, stay out for a while, please. Just let us just finish. The Taxotere or docetaxel is the chemo.
Okay.
And what you told us that Kwon wanted to do back in May was Lupron plus docetaxel or Taxotere.
Yes.
And
And
what we said was, that's really weird because we can see you doing Lupron plus abiraterone or Lupron plus abiraterone plus Taxotere, docetaxel, but we can't see you doing Lupron plus chemo. But so I'm trying to figure out where all of a sudden did this abiraterone come from? Who introduced the abiraterone?
medical oncology, Minnesota oncology,
Okay.
Dr. Herjik.
Okay, so that's a good move.
Okay.
If Kwon would have said that in the first place, we wouldn't have been so skeptical and down on Kwon.
Okay.
But he blew it. In our view, he blew it. And fortunately, his buddy at Minnesota Oncology stepped in. And now I understand why both Dr. Antanarakis and Dr. Heath are saying, yeah, what was recommended is fine. Well, it was fine once he got his oncologist involved. Are you appreciating this nuance here?
Yes, I am. I am.
Because you probably warranted what's called triplet therapy, and what Dr. Kwon recommended was doublet therapy, and it wasn't even the conventional doublet therapy. It was the unconventional doublet therapy. You know, Ben's starting to smile, and then he shuts his camera off when he starts to smile. You know, I don't know what's going on there with that, Ben. But this is how we see it.
Sure.
So yes, I think you're fine with Minnesota Oncology. See how you do. Frankly, if it were me, I would. Is the Minnesota Oncology Clinic very close to you?
Well, they actually have like 12 of them in the Twin Cities area. It's like crazy number of them.
Yeah.
But it's 2 hours away.
Okay. If it were me, I would flip over to one of those two as your quarterback. It's your choice.
Well, yeah, and I strongly hinted at wanting to do that, but they pushed back and said that
Okay.
they would be there if I needed them, but I should stick with my
Okay.
standard of care program that was in place.
Okay. Well, yes, because you're now getting standard of care. We pushed you into this because you weren't getting standard of care before.
Okay.
That's the whole point.
Sure.
Okay. And you like them, I assume. You like both of them. They're different, but they're really great, both of them.
I was just, terribly impressed with how wonderful both of them were, both from a interpersonal relationship and from a knowledge relationship.
Yeah.
They're really smart, and I learned a little something about Mayo Clinic, and that is that not only are they spending $2.6 billion on their Rochester campus, but a big chunk of money is going into AI. and bringing in state-of-the-art AI, whatever their handlers are called or whatever. You know, it sounds to me like Mayo Clinic Rochester is looking at really elevating their whole treatment protocol and knowledge base
Okay.
and staffing. And
Well, it's not that they need to do. What they need to do is improve their culture so they do a better job working with other people in different departments.
yeah, that's true.
And that's got nothing to do with AI. They can spend as much money as they like, but if they don't work together, it's not going
Yeah.
to do them much good.
Yep. That.
All right, I'm going to keep moving on, Mr.
Thank
Blomquist.
you.
I'm glad we got you straightened out. I'm very, very glad to hear that you're doing triplet therapy, which is what we thought you needed from the beginning. And how do you spell the name of your doc at Minnesota Oncology?
Let's see. It's Russian. I think it's Hurgec.
That's
Hershek, I think, something like that.
that's close enough for government work. We could work with that. All right.
I'll send it to you.
And now we got you on the way, and you're getting your chemo. Keep coming back because we'll help you in terms of tolerating that.
Oh yeah, I'll be here.
Okay.
Right.
Okay. Good job. Thank you. All right. Who's next on my list? On my list, I've got Richard Fisk. He left. Lee Balin. He left. Richard Craymond. He left. Ah, they all left. I will be sending notes to. Didn't I to Dr. John so he knows who to give a priority to next week? And Tim, are you there this time? Calling Tim. You're muted right now.
You should have me too on that list.
No, you did not say yes, Harry. Or if you did, my bad. I didn't write you down. I'm terribly sorry. I think it was my bad, to be honest.
Yeah.
And I'm so sorry, but I'm glad you spoke up, and I'm happy to listen to you.
Okay. All right. Thank you. All right. I was here about 6 weeks ago, and
We remember.
Yeah, and I came in because my scans have been very stable and pretty much clear, and I'm asymptomatic, but my PSA has been rising. So since then, and you recommended that I go look for a second opinion, go to a center of excellence. So I turned to Johns Hopkins, and I got an appointment with Dr. Paler.
Oh, good.
And she was good. Just as everyone said, talks very fast, but very impressive, high energy, which is something I'd been really looking for, and had lots of things to recommend. She recommended a clinical trial, and then she had a clinical trial behind the clinical trial. Now, in the meantime, in Fairfax, I had a PSMA PET scan ordered, and it came back what to me seemed remarkably clean. They said there were no evidence of PSMA positive malignancy at most sites, and the only place they found it was in 2 small presacral lymph nodes and increased activity along the mesorectal fascia. So that's, and my PSA is rising. Yeah, my PSA in June rose to 4.75. Seems to be doubling about every 6 weeks to 2 months. Anyway, I asked Dr. Paler and Dr. Aragon Ching, my regular oncologist,
right?
Could I be? Because I found in the literature the term oligometastatic disease.
Right.
And would it make sense for me to go to a radiation oncologist
Right.
see if my few spots might be taken care of that way, could be beneficial. What do you think of that therapy?
I think it's a great. I think if you can do it, it's a great option. The only concern I would have is that your spots are in places where you could suffer side effects. So you need a damn good radiation oncologist who knows what they're doing, because you don't want to finish up with with bowel issues. I mean, look, they're manageable. I have them, but I don't want to see you finishing up. So you've got to have a straight and honest radiation oncologist who tells you whether he thinks or she thinks that they can zap these spots.
Right. Is proton therapy preferable to cyberknife therapy?
Okay, those are not the comparables. Is proton therapy comparable to photon therapy? Is the comparable. Cyberknife is just a more directed energy, and you can have cyberknife with proton or photon. It doesn't really matter. Okay, people will sell you proton, but the evidence just isn't there to support it. The proton proselytizers would disagree, but we just don't have the evidence. So I would say you'd be doing, it's a good way to go. What did Dr. Ching and what did Dr. Pala say about what they now call MTD?
Right.
That's what you'll see. MDT, metastatic directed treatment.
Right. Well, they both weren't really recommending that to me, but they both said that could be a good way to go. Why don't you talk to a radiation oncologist? I got an appointment with one at Sibley at Johns Hopkins, and then Dr. Aragon Ching recommended that I speak to Dr. Nasser at Virginia Hospital Center, because he's already done some radiation. He did the original radiation when I was first diagnosed, and then he's done 2 other rounds of it, to the pubic ramus and to the prostate bed. Yes, and one of them talked to me about being oligoprogressive in that category within oligometastatic.
Well, here's the problem, that they tend, I would speak to both, see what both of them say, but they tend to be influenced by the equipment they have. And so they're going to tell you this is the best way to go, and sometimes it doesn't matter. So whoever you like best and you think they can do it, I think it's a good starting point. I mean, just remind me, what are you? You went through the PARP inhibitor, and what are you on any hormone therapy at this point in time?
Yeah, well, I've been on ADT. I started this stuff and I've never been taken off this stuff. So I'm on Eligard, and I've been getting that every 3 months for 5 years. I'm still on abiraterone.
Okay.
I've been on that. So they've kept me on olaparib even though the PSA has begun to rise.
Okay. And did you talk to them, either one, about Pluvicto?
Yeah. So we talked. What they really had to say was, they said, listen, if you want to go to a radiation oncologist, they'll probably tell you that they're ready to do the MDT. But certainly have those conversations and talk to them. But they were both recommending clinical trials. Dr. Paller first recommends the step-up trial, which has to do with giving high levels of testosterone in a certain regimen with enzalutamide.
Right.
And then following that, she suggested a trial with Pluvicto.
Okay.
Dr. Aragon Ching has me looking at
Yeah.
a trial with a Merck drug that's coming out
Yeah.
that
Yeah,
looks
I
at
see
another
it.
pathway.
Yeah, I see it. I've got a note of it, the Omaha 4
Right.
Oplovisostat trial, which I don't want to say it's sketchy, but it's out there. Let me ask my smiling moderator friend, who is so kind to have stayed with me to the bitter end. If you were Harry, where would you be going, Mr. Nathanson?
Certainly not to the Merck trial. Nothing against Merck, but that out there is a good way to put it.
Would you say that it's a bit of a murky trial?
If I were clever enough to have thought of that, I wouldn't be. Yeah.
And why is that?
It's a new avenue of therapy. It's not it's not an incremental change to what's been done before. I mean, it's very important that people volunteer for these trials so that they can actually test these things. But the people who should be volunteering are those who have limited options. If you have the option for Pluvicto, it's almost axiomatic that you should be taking Pluvicto and not going on a limb with a novel kind of therapy.
Okay. And what do you think of BAT, the whole business with the high level dosage of
Right.
testosterone?
So you're established to be castrate resistant?
Yeah. Yes. Yeah, we're seeing him going up on Eligard and Abbey right now.
I mean, sometimes it works.
Yeah. Here's the thing that we've seen with BAT, Harry.
Yeah.
For most guys, it does work, but they don't get a lot out of it. So some guys, they'll get 4 months, 8 months. Some guys maybe get as long as a year or 18 months. I mean, it's a positive therapy. It's relatively tolerable, but it's not very durable. And it's something you can still do. Now, you know, you could still be playing the whack-a-mole game, which isn't a bad thing to do for as long as you can do it. But I think that if I were you and looking to do systemic therapy at this point in time, and it's a surprise to me and a very positive surprise that we don't see a lot of metastasis. That's great. I still think I would go for Pluvicto and maybe not even 6 treatments. Because as you heard with Chuck earlier on, when you burn up the 6 treatments, it's very hard to get more treatments right now. I don't think it will be in the future. I think they'll approve more treatments. But, you know, you could do, if I was in your position right now, I probably would look at how feasible it is to do spot RT with the position of these metastasis, and if they think they can do it without damaging anything, and you may even have to look at some sort of a rectal protector, which they don't usually use in spot, but if it's in a very sensitive place, they might want to do it if it doesn't affect the way they're going to radiate you and the area. And if I couldn't do that, I might go for 1 or 2 treatments of Pluvicto and see how it does, and then see where you are at the end, and if you respond to that, and still keeping some Pluvicto in my pocket.
Going into doctor prescribed Pluvicto or into a clinical trial using?
No, you're eligible for it now.
Yeah. but not the
Yeah,
clinical
it's
trial.
been approved. They could give it to you right now. You don't need a clinical trial. You're approved for it. So, I would be challenging Ching and saying, what about Pluvicto?
Well, she wants to hold it back, and from what I've been
So
reading, I
do
thought
Plu.
maybe I need to have more disease burden to
Well,
make a
yeah,
difference.
that's why I'm saying, but you don't want to do chemo. And you could do chemo. That chemo is standard of care. You've got Pluvicto, that's standard of care. So there's two standard of cares we've got. Why are we looking at clinical trials when we've got two standard of cares and we have metastatic directed therapy? There's three options on the table for you. We don't need that right now. And it gets back to this academic conflict of interest where they're looking for fresh meat. And then they sell them to you, they sell it to you as the best thing since sliced bread. And then you come to somebody who has a little bit more knowledge and they're saying, but why? I mean, just like Ben said, if you didn't have any more options, yeah, okay. But you got good options.
After Pluvicto, could I get onto the chemotherapy?
Sure.
Yeah.
Now we think, but we don't know that it might be better to do a little bit of chemo before the Pluvicto, but that's a hypothesis. We don't have the sequencing down. What happens now versus 6 months ago is we can offer you Pluvicto before chemotherapy, which we couldn't do before. You would have had to have done at least some chemotherapy for Pluvicto. That's changed.
Okay.
Rick, what do you think of genomic testing to see if he's a good candidate?
For
the Pluvicto, to see if he's got the mutations that make him likely to be less successful.
Yeah, I think it's a great idea. When was the last time you were sequenced?
Yeah. Well, first of all, I'm BRCA1 mutated.
Right.
And
Somatic or somatic, right? Not germline.
Germline.
Oh, germline. Okay.
And number two, I had a liquid. I had a second liquid biopsy, and there are two other mutations that come out in very small quantities. I thought I had it here.
I mean, it's only interesting if they're listed as actionable.
Yeah, the BRCA1 is the one it was a Tempest liquid biopsy, and it only listed things relating to BRCA1. It's actionable.
BRCA1's actually a little problematic. It's not as necessarily as significant an actor as BRCA2.
Right. It's nowhere near as clear cut as BRCA2. But what were the you don't recall what the other two were that they listed?
Yeah, I found it. ASXL1. I'm in there on 6%. TET2, 1.2%.
So does it say something like VUS, variant of uncertain significance?
Yeah, that was the next section, right?
Yeah,
so,
the VUS is, yeah.
When was this done?
This was done in May.
Okay.
Variants of unknown significance. HSP9.
No, we don't even want to hear those. No, save your time.
Okay. Yeah, there's two of them. All right. But that first one is 47%.
Yeah, I don't know. I'm not familiar with ASXL1 at all. Are you, Ben?
No.
It doesn't ring any bells that would indicate that there was a treatment for it. And did they say it was actionable or not?
No, it says it's relevant, biologically relevant.
I'm not sure. I'm not sure what that terminology means. Ben, what is biologically relevant?
Um, um, it's not just some weirdo that I mean, my understanding would be that it could plausibly be playing a role in the cancer.
All right. So, Harry, I want to get to Bruce Shrimp, who's hung in because he's got a question and I want to answer it before we finish off. But
I just have one more little one. What about shifting to a different PARP inhibitor?
it's never been shown to be effective to date. It doesn't seem to make a difference. We don't have any evidence that going from one PARP to another PARP is going to help you. Now, what may help you is to do a treatment and then re-challenge with a PARP.
Do a treatment and then challenge it with a PARP?
So re-challenge with a PARP. So let's say you did chemo and then you could try a PARP again afterwards. Let's say you did Pluvicto and then you could challenge with a PARP afterwards. But challenging with a PARP again later down the road with another systemic treatment in between, it probably wouldn't make a difference with the MDT, but it might make a difference if you did one of the systemic treatments in between.
All right. Thank you.
So I don't know. Have you decided who you're going to move forward with, Dr. Bala or Dr. Chang?
Well, they say they work together well, and they say I can continue to see both, but whoever, they're sort of were directing me towards a clinical trial, if not immediately, then after the MDT, and then to see the one whose trial I end up with.
Okay, well, I would still be pushing for a line of, unless there's something amazing that comes out of these trials, which our famous bird dog in New Jersey keeps his eye on so that we know. So, if all of a sudden opevesostat seems to be the best thing since sliced bread, we'll let you know. But I would stay away from the trials until,
If it's a phase 3 trial, you may not be getting that drug. If it's an earlier phase trial, the toxicity of these things is not well established.
Right. Well, that's
you'll definitely be getting the drug, but what may happen to you is not clear.
Right. One's a phase 2 trial, the step up with the bat, and the other's phase 3, the Omaha. All right. Okay. Well, again, I don't want to take time, and I know it's getting late, so thank you for squeezing me in. And I did ask the question, so I appreciate you recognizing that. All right. Have a great evening. Thank you.
Come back within 6 weeks.
Yes, of course, obviously.
Come on back, and then we can take care of biz.
Okay.
Okay. Now you had a question, Bruce, that I couldn't really read. What was your question, and how can I help? How can we help you?
I'll read it. In recommending that my case be reviewed by Dr. I'm the guy that's going to the Mayo Clinic. Heath at Mayo, are you suggesting I should be getting my prostate or what's left of it removed? Is that why I'm going to be seeing her? And that was the question that came up to me.
So we're definitely not suggesting you get your prostate removed. For sure.
All right.
Okay. Was your prostate? I've got to call up your history. So was your prostate ever just bear with me 1 second. I've just got to put a couple of notes in here before I go off of Harry's. Off Harry. Okay, save and then shrimp. Was your prostate ever treated before?
Oh, sure.
Well,
it was treated starting in 2018 with proton beam at the Mayo Clinic.
Okay, so the answer is because there are some people who are de novo metastatic and they don't get their prostate treated up front. And so those are the people that we say, okay, we should come back now and treat. But the answer is no. I mean, the answer is just no. No, we're definitely not suggesting you go there to have your prostate surgically removed, even though they do like to do that. We know they have that's a long-standing history with Mayo at that location in Rochester.
Okay, so what's going to be going on is that right now, this is the second recurrence, and I'm going to be headed for cryoablation. And that's going to happen on August 1st.
And
unless I stop it.
And have you so again, have you made the appointment with Dr. Heath to see her?
No, I have not done that yet.
So what we're saying is, why are we messing around with the prostate when maybe you need a different type of treatment? Dr. Stish likes focal treatment. And we don't know that your disease is focal, and we want you to see a qualified medical oncologist who knows how to treat you systemically. The problem with Barry Blomquist was that Dr. Kwon, who is the equivalent of Dr. Stish except on the surgery side, wanted to treat him with insufficient and the wrong treatment. And when he got to Minnesota Oncology, they said, no, we need to add something to this. This is incomplete. Now, I don't know that Dr. Stish, since you've had 2 recurrences before, he's putting another Band-Aid on it. Now, maybe he can put a Band-Aid on it, except it's actually in the gland. And I would rather see Dr. Heath sprinkle her holy water over that before you go off and do it. If she says yes, it's a good option, fine.
Okay.
That might not be the best option for you.
I have a telephone appointment coming up with them, I think within the next week. And I can at that point say, look, I want Dr. Heath to review this thing.
Well, they're not going to do that unless you make an appointment with Dr. Heath. You don't suggest to them, I want Dr. They won't go there. They don't do that. They're in their castles. They don't want somebody looking over their shoulder.
All right.
All right. If you want to see Dr. Heath, you can tell him, I want to see Dr. Heath before I go there. I'm going to make an appointment with Dr. Heath, and then I'll come back to you if Dr. Heath says it's fine. But if you say to them, yes, I want Dr. Heath to take a look at this, they're not going to take it to Dr. Heath. They don't do that at Mayo. They don't work that way.
That's useful information. All right. Well, I appreciate it. Took a long time, but I appreciate the information. Now I've got a better idea of what's going on.
Okay. Did you tell me you wanted time? I didn't think you did.
No, I didn't. But as I was sitting through the whole meeting, and towards the end of it, the name of Dr. Heath came up.
Yes.
From one of the other participants, and
yes, and she's lovely.
And I thought that was useful.
She's lovely. She's great. She's super smart. You can't go wrong with Dr. Heath. Okay, And you heard what she said. She didn't even try to convince Barry to come to her. She said, "Do what you got to do. And when you're ready to see me, I'm available for you." That's the sort of doctor she is. That's why we love her so much.
All right.
Okay.
Well, I appreciate this.
Okay. All right,
When
guys.
is the next time we're meeting?
The next time we're meeting is next Tuesday, the 15th, with Dr. John in the hot seat. And that's it. And can I go home now? Am I excused?
You can go home.
It's a marathon. 8:07, 3 hours and 7 minutes. And I've got to write it up tomorrow. Okay.
Good night.
Bye-bye.
Good night, everybody. Good
Good
night.
night, everybody. Good night. Thank
Good
you.
night.
Thank you.